I would like to first of all thank the organizers of SAARC meeting, this SCR meeting. And the reason I'm here today is it's actually a very bad time for me personally. Back home, we are just inaugurating our new MRI Center. But I have so many friends back in Bangladesh that I couldn't say no to this lecture and I couldn't cancel it later on when the inauguration got fixed. We have so many of you coming to Bombay as observers, and we actually like sharing the time with you all. And what I find is that there's a lot of warmth in the people who come to Bombay from here, and we have very, very sweet memories of a lot of doctors from here. So let me first take you through, I just changed the pattern. I'm going to do spectroscopy in the second lecture. We'll look at something which is very state-of-the-art, the arterial spin labeling. It's a new technique which I hope you all find interesting. We have started that. I started that when I was in Nanavati about a year and a half ago. I worked on ASL there on a new 3 Tesla machine for 6 months, and then I shifted to Global Hospital. Global Hospital is a center, very, very upcoming and promising center in the heart of Mumbai next to KEM Hospital. Most of you know the King Edward Memorial Hospital in Mumbai, and luckily for me we had the same magnet there, the 3 Tesla 750 WGE Discovery, and I could use my experience from Nanavati on the same machine. And we've got a lot of cases. What I'm showing you is data till January 2015. After that we have another 400 or 500 cases which I'm going to present in one of the conferences in Dhaka now, which is about a consorted experience about 1,000 plus patients. So let's look at what is available when we want to look at the brain parenchyma in terms of cerebral blood flow. So what are the types of perfusions available? The conventional is dynamic susceptibility weighted imaging, in which you give a contrast to the patient and you rapidly image that passage of contrast in the brain, which we call as dynamic study. So that's called DSC. But there are some limitations in DSC. And we will look at principles of ASL. How did ASL come into picture? We look at some literature, some examples, and our experience, and maybe encourage you all to use it in practice, as in how you all have the newer magnets and the newer software. So what is that we're looking at when we're measuring perfusion in the brain? We are looking at cerebral blood flow. And what does it mean? That means how much of blood is flowing through every minute in 100 grams of tissue. And that already is measured by other techniques such as PET and even when they use oxygen, etc., to see how much flow of blood is there. So this is already known and established. So it's about, in the grey matter we already know it's 50 to 60 ml. In the white matter it's about 30 to 35 ml. It's higher in children because the brain is developing, and it's lower in elderly like us because it's slow, the brain becomes slow as we grow older. And types of perfusion, so again let's revisit. T2 star imaging, as we call, is called as dynamic susceptibility weighted imaging. And we also have a T1 weighted perfusion, which is very more reliable in terms of parameters, but it's cumbersome to do and not everybody has this software. It measures the permeability constant, which is the K trans, and is the best in terms of measurements of absolute values. But we have to usually do with the T2 star imaging, and now we have this arterial spin labeling. The whole world is now shifting from contrast imaging towards the use of non-contrast imaging, because we want to try and save the toxic effects and as well as save on the cost. So we have, as you saw in the earlier image with the new machines, the SWI imaging, that is susceptibility weighted imaging. So that gives us an idea of how much of blood or hemorrhage is there in a lesion. If you add arterial spin labeling to it, you have a non-contrast examination which tells you that you're looking at a high-grade neoplasm. So you don't need really contrast to tell you what we earlier wanted to see, contrast enhancement, etc. So in both of these techniques, what are you doing? You are allowing rapid passage of blood through the brain parenchyma. You are concentrating on collecting data in the brain parenchyma. The tagging of the blood which is flowing can be in two different ways, by contrast, or it can be because you have labeled the drug either with a magnetic tracer or by altering the parameters of that flowing blood. Let us see what do I mean by that. So first let's look at dynamic contrast weighted imaging. This is a color map and this is how the blood flow in the brain looks. The red color is the area where there is more blood flow. As we know, these are sulcal vessels and the cortex which is getting perfused. And the blue color is the white matter, where we know there is less blood flow compared to the cortex. What happens in tumors is they secrete substances such as VEGF and EGFR. These substances in turn induce production of new vessels, which were ideally not required for normal brain parenchyma but are required for the tumor tissue to grow. These are more in number, they're abnormal, and they have leaky vessels, and that's why you have more blood flowing to that area, which you can measure by using cerebral blood volume. Now coming to the pitfalls in T2 star imaging. So this is how area of susceptibility will look on even routine images, gradient echo images as we call them, and this is, it appears dark. Now when you have susceptibility weighted imaging, that means T2 star imaging, you see that this area, which is where the blood is flowing in a larger quantity, also becomes dark. So you cannot differentiate between the blood and the dark areas. So this is a technical pitfall. That means if you had a hemorrhagic lesion, you would not be able to assess perfusion in that area very accurately. You would have artifacts. Plus bone also has susceptibility, so if there were areas which were close to the bone like the base skull, you will not be able to do a good perfusion study with contrast. Again, the same with paranasal sinuses, because air causes susceptibility artifacts. Plus, if you have to give contrast, you can't go on repeating that study in patients who have been uncooperative, especially in the setting of pediatric imaging. And quantification is not possible. What do we mean by that? We are assessing relative values. That means we would look at an area here and then try to compare it with that. That means we're looking at a relative value. Absolute value is not possible on dynamic susceptibility weighted imaging, and that is why the calculation of RCB is inaccurate, especially when you have these breaks in the blood-brain barrier. Now coming to an introduction to arterial spin labeling. What are we doing? We already have water in the arterial blood which is flowing through the brain parenchyma. We are trying to tag that and measure how fast or how slowly and in what quantity it is flowing through the area of interest. Now the problem with this is it has low sensitivity. That means what? It means that the signal is so small that you need a higher field magnet to assess it. Technically you can do it even on a 0.5 Tesla, but you will have measured signal which you cannot utilize for interpretation. That means you go 1.5 Tesla and above, it's what we call as high field magnets, and 3 Tesla is much more reliable than a 1.5 T. And coming to why ASL till now did not become very popular, although it was known for a long time, is because of the evolution of the magnet strength and its availability in the clinical practice. Also about some techniques that had to be evolved, that means the hardware and the acquisition had to be evolved before the technique was utilized in clinical practice. So let's look at how actually we do an ASL study. So in the first image, in the first step, what we do is this blue slab that you see is the blood getting tagged by a magnetic field in the neck. So what happens, this is the slab where we will have the yellow band is where we will actually acquire the data. So we acquire the data with the tagged blood flowing through. Then we repeat the whole study. Somebody from the audiovisual will have to come and help me here. The laptop is losing battery. Is there anybody who can help the audiovisual? So we repeat the study without the tag, and then the difference is what we measure as CBF or cerebral blood flow. It just dies down if you have no lecture. So, okay, so what happens with DSC? One advantage is that we can measure several parameters in dynamic contrast study, where you have CBV, CBF, mean time to transit and time to peak. But in ASL, the only thing you can measure is CBF. But the advantage is that you may be able to do an absolute quantification if you did correct post-processing. not in the clinical practice, but you would need special workstation for that with SPM processing, etc. If some of you are looking at a lot of tumor patients, then you must make sure that in your protocols you have gradient echo imaging. That means if you have the newer SWI, that is even better, or on GE we call it SWAN, susceptibly weighted angiography imaging. Make sure you have a good coronal T2. It really helps you to look at details very clearly, as you saw in the earlier lecture. So many times when we have these scans coming to us from outside, we find coronal T2 missing, we find gradient missing. Another thing we find missing is diffusion weighted imaging. That also really helps a lot. So these things, if you make sure you have in your protocol, that it will help you to monitor these patients better, especially in the setting of radiotherapy, etc. So we have, okay, we did look at this. If there's any doubt on this, I could go through it again. We first tag the blood in the neck, wait for a while, acquire the image of the brain, then repeat the whole thing without the tagging, and we have a difference. We have two sets of data. One is subtracted from the other, and the difference is what the CBF map will look like. We have, how do we, I mean, like just like you have press and steam, and in spectroscopy, you have different techniques how you can acquire this data. Continuous ASL, pulsed ASL, and velocity selective ASL. So these both have different issues. One has of longer time, one needs a wider labeling slab. So if you did so much of slab labeling, then you would not get data over the cerebellum. And if you did, if this whole thing was done as a continuous labeling, it would take a longer time. I'll come back to what is the resolution, how do we resolve this problem. But before that, a word about velocity selective ASL. This is a very exciting technique that is available. Eventually, as progress is being made, what we will find is that you tag one blood in one artery in the neck, like say for example you tag the left internal carotid artery, you will be able to see the blood flowing through only the left internal carotid artery. So it will be like a DSA imaging. You will be able to separate out the blood flow between right side and left side, plus each artery individually, say external and internal cerebral arteries, carotid arteries, and that is very exciting because you can actually avoid a lot of invasive procedures. I know some neurointervention people here will not be happy when I say that, but you can avoid some of the invasive investigations. So now the solution to the first problem that I showed, the problem I showed you on the earlier side is a combination of the two, and this is called as pseudo-continuous labeling. So that is why we had to wait till it became available in clinical practice, till this was developed. And in this you combine both. That means you take a smaller slab and faster time, cover the whole brain. It gives you a good SNR, signal to noise ratio, and so now it is, because of the improvisations we are able to use, coil technology changed, we have better coils now, and therefore we have higher SNR with 3 Tesla, etc. Pseudo-continuous labeling was developed, and main thing is that there is good background suppression with the newer magnets, and that's why now we are able to use ASL so well. This is how the ASL map looks. This is the raw data. You can put color to this, just as we saw in the DSC. So what it means is the cortex is white. That means there is more blood flowing through that. Black areas are the white matter, which are showing less flow. So on a grayscale imaging, white is higher flow and black is lower flow. So this is the work which has been done on this, and almost starting from 2003 studies as well. So first time in 2003, they looked at 36 patients on 1.5T and compared a pulsed ASL to DSC. So when we look at studies, we must know which technique they used, whether it was pulsed, continuous or pseudo-continuous. And then they suggested that it is possible to use ASL to differentiate low grade versus high grade. And also whether these tumors will respond to treatment or not was possible to explain. Now just let's look at the values. A low-grade tumor would have something like 32 to 65 ml. High-grade tumor would have 108 to 208 roughly. So what it means is this low-grade is almost like the white matter values I showed you. High-grade is about twice to thrice of the cortex. Metastasis is about 4 times the cortex. 4 to 6 times the cortex. And if we already know what is the data available with DSC.
for low versus high. So if it is 0.64, then we're looking at a low grade. That is our tumor blood flow versus normal white matter blood flow. And if these are the values, then we know we're looking at low versus high. And the same things if you measure with ASL, we have a good correlation. Why is this important? Because the clinicians are used to looking at DSC, and we have to prove to them that no, ASL is as sturdy as DSC. So this is another study in which was done in 2014, and what we have done matches this study. It's the same magnet, 750WG discovery. DSC was done in all the patients, ASL was done using pseudo-continuous, and they confirmed the potential for non-invasive alternative for DSC, especially in the setting of treatment prognosis, and especially if there is renal failure and you do not want to give these patients contrast. So we looked at, let me take you through how the technique is actually done. So in addition to our tumor protocol, we added ASL using the head neck unit. We use the orthogonal plane. That means it has to be dead axial because you want to make sure that tagging and the acquisition is linked. So if you take an oblique plane, then you will not get an accurate idea. We take about 4 mm thickness slices. The idea is to leave a bit of the posterior fossa out of the acquisition field because there is some time delay before you can get information. But every time I have a cerebellar lesion, I move the move the acquisition slab down, and we still have good results. So you can vary the technique a little bit. This is important, post-label delay according to age. That means the vendor will give you specific values which you need to insert. Train your technicians to insert it in the column, in the box, because without that we will have some errors. That means children have different values, elderly have different values, and middle age have different values. So there is a set of 5 values which you must make sure that the technician is tuned to putting into the box. And you if you want to learn for your own sake, then you must match the perfusion planning to the ASL planning till you get confident about replacing one with the other. In post-processing, I told you what we do: normalize to the normal contralateral location, preferably the white matter. And this is important in ASL. In DSC, even if you look at the color map, you can get a fair idea because it is more sensitive as to whether there is a hypoperfusion or not. But in ASL, in my experience, you have to look at the anatomic overlay very carefully because there are subtle, I will show you examples, there are subtle issues with that because of the low sensitivity. So we have looked at about 230 patients till Jan, of which some were index and some were follow-up. I had a problem in about 41 patients in contrast perfusion in terms of either a bad IV line or patient moving or susceptibility artifacts. But both were satisfactory in 165 patients, so I could compare both. We had good concordance in 146. That means RCBF from ASL and RCBV from DSC matched, but we had discordance in 19. We will look at why that has happened. Now let me show you examples. So this is an ill-defined hyperintense lesion in the insular parenchyma, where it appears on morphology as a low-grade neoplasm. This is the DSC data. We do not see any abnormality in this location. So I told you can measure CBF as well as CBV with DSC. Now look at CBF from ASL. We can measure only CBF. So this is the raw data and this is the color map on the anatomic imaging. So if we see carefully, we see this area of more flow on the left side compared to the right, and that is also depicted on the color map. So in fact, in the low-grade lesions, ASL has more sensitivity than DSC. Let us look at an example of a high-grade neoplasm, lot of variation, but no contrast enhancement. Will we call this as a low-grade or a high-grade? Because of the mass effect, the size, and the heterogeneity, we will want to make sure that we tell our colleagues that they're looking at grade 3. Now why is that important for us to tell? Because if the surgeon samples from this area and the pathologist looks at it, he will call it as a grade 2 because of the pathology at that site. That means we have to tell them where they should be taking the biopsy from. So this is the ASL map. Here there is no flow, or it is even less than this, so it is low grade area. But you see this area which is also non-enhancing but showing a lot of blood flow. So this is the area when sampled which will give us the correct grade of the tumor, which is grade 3. This is how the perfusion looks. This is the raw data of the perfusion. This is the artifact coming from this paranasal frontal sinuses, which do not allow an accurate acquisition. So we see this here. This is a color map, and you cannot see the exact area of hyperperfusion, but in ASL you see it so beautifully. So this is much more sturdy when we are looking at lesions close to the base skull. Just to show you the example again. So in the DSC perfusion, we are not seeing the area of hyperperfusion well. This is the post-operative study with an ASL map. What is important is, because we told the surgeon to target this area, he has not taken out periphery, but he has taken it out centrally. And after the post-operative ASL, we can show them that that area is completely out and the representative sample will be achieved. So this is a glioblastoma, which again shows good CBF. So compare DSC with ASL, we have comparative images of high blood flow in the periphery. Now what is important is to know what has been left behind after the surgery. When you do DSC here, you could have artifacts because of the blood in the wall of this lesion, but in ASL you do not get those artifacts, and this is a reliable area of hyperperfusion which is seen in the tumor bed. The arrow is not seen from the computer, no? Okay. So this is a case of multifocal lymphoma. This is diffusion weighted imaging, which is showing this area of restricted diffusion in the left temporal lobe, and there are multiple enhancing lesions, okay, in the splenium of the corpus callosum. Perfusion, we characteristically know, does not come up very well in lymphoma cases. So this is the one in which the distal segment is going up, and this confirms the low perfusion expected in lymphoma with persistent upward curve. But in ASL, if you see, all the lesions show increased CBF. Just make a note that this entire cerebral hemisphere is showing less flow, and that is because of this lesion here on the right side, which represents an arteriovenous malformation. So there is a steal phenomenon. All the blood from here is being sent and diverted to the right side. So again, reliable in lesions such as lymphoma. An example of hemangioblastoma, the enhancing nodule is low down in the cerebellum, but still we can get good images with ASL study. These two are the perfusion studies, and you don't see the blood flow very well. But on the right side, there is a good flow, which is an ASL study. Medulloblastoma, high-grade tumors in children, again, consistent results. This is interesting. This was a lady with breast cancer. She had 3 lesions, which were treated with stereotactic radiosurgery. Only one was growing. They would not believe when I said that this is growing metastasis. The question was, if the other 2 responded, why one is growing? And so I had to prove to them on serial ASL imaging that there is increased blood flow consistently. So this is just the color map, and this is color map overlaid on the anatomy, and you can see the enhancing lesion showing more flow. And why was this very important? Because we could not get a good IV line on her because of her chemotherapy treatment. So ASL was the one we could resort to. Coming to grade 3 astrocytoma, in this patient who responded very well after surgery, and there was a new lesion coming up on the opposite side, as you can see here in this side, and I was sure we are looking at a recurrent neoplasm because the cortex was involved, but perfusion was not showing any increase, and but the lesion increased in size, and ASL was positive before the perfusion was positive. The whole red area which you see is the new enhancing lesion, and it is showing increased blood flow. After 4 months more, it increased further in size when perfusion became positive, but ASL was positive before the perfusion, so it has very high sensitivity. Same type of lesion in another patient, a new enhancing area in the periphery of the ventricle, and what we have is central necrosis also on the contrast study, and no flow on ASL, completely no flow. In fact, the whole cerebral hemisphere on that side is showing lack of flow. Another example of recurrent disease, it is a left frontal lesion which has been operated, and what we see on the right side, there are about 3 new lesions. One is in the right frontal and 2 are posterior, and perfusion just showed mild enhancement where the arrow is. But see the ASL map, all the lesions are showing high flow. 1, 2, 3, all the 3 lesions are showing high flow. So ASL is quite reliable in the post-treatment setting, but we have false positives with DSC with blood products, as I showed you. Early recurrence, we cannot diagnose well with DSC. Proximity to skull base, small lesions, lymphoma, these are the problems with DSC. But in ASL, we have had other problems. Enhancing areas in pilocytics, although it's a low-grade tumor, shows high blood flow, and some infective lesions in the setting of tumors, especially in leukemic cases. So this is a patient, a young child in leukemia who came with, on treatment for leukemia, who came with convulsions, and we have this bright area here. I almost thought that meningeal enhancement will come up because this must be a chloroma with underlying edema, but there was no enhancement, so I was puzzled as to what we are looking at. ASL showed high blood flow, and this we concluded was acute encephalitis. This is follow-up after viral therapy, antiviral therapy. Another example, again leukemic patient showing multiple hyperintense lesions on the left side. So the problem is in these patients treatment can cause subacute ischemia, and so we want to rule out ischemia versus encephalitis. Both can appear bright on diffusion, but only one will show high blood flow on ASL. And this is again showing multiple hyperintense lesions with increased flow. All the red areas which have been marked are increased flow. This is the raw data, which is a grayscale image. And on follow-up, everything after antiviral treatment has resolved. So this is the example of pilocytic, where the enhancing area is showing more increased blood flow on ASL but not on perfusion. So this upper image is DSC, in which it is hypoperfused, and the false positive on ASL, where there is increased flow on the enhancing areas. So the advantages of ASL are that it has a potential for quantification of blood flow in a non-invasive manner. If we do correct post-processing, it can measure absolute values. No contrast is required, so it is easily reproducible, and you do not require large bore catheters, especially in pediatric patients and patients who are treated with chemotherapy. Disadvantages are that you have low SNR. If the patient is moving, that may be an issue, but that can happen in any MR study. And we are assuming certain parameters, like I told you, the post-delay label, which we do not know whether we are accurate on that. Some more research is required in that. And just to conclude, that it is a non-invasive means of measuring CBF and a reliable alternate to DSC. I thank you for a patient listening, and if there is any question, I will take it.
You're spending 5 minutes more on the patient, and post-processing is also within 1 minute you can do it. So it's not a very big, difficult test to do. Thank you again.